Hello, I'm Dr. Marla Shapiro. I'm a past president of the North American Menopause Society, and I'm joined today by Dr. Amanda Clark. She's a senior affiliate investigator at Kaiser Permanente Center for Health Research. She's a well-known urogynecologist, a menopause physician, also at Kaiser Permanente Northwest. She's an affiliate associate professor of female pelvic medicine and reconstructive surgery at Oregon Health and Science University. And there was no one better than you to join me today to talk about some of the most common urinary symptoms that occur in midlife women. So can you go through some of those for us?
I would be happy to. So the three conditions I think most of for midlife women are stress urinary incontinence, overactive bladder, and frequent or recurrent urinary tract infections. Stress incontinence would be leaks with coughing, sneezing, exercise, overactive bladder, the sudden strong urge to rush to the bathroom to avoid leakage. And then, of course, urinary tract infections, which become more frequent as women get older and pass through the menopause transition.
So let's start first with something that is a relatively easier fix. Bladder infections and the role of menopause and estrogen, a word to our healthcare providers.
So estrogen is a really important factor in the bladder's defense against urinary tract infections. We're not sure exactly why, but probably has to do with maintaining a vaginal flora that prevents infection. So that's the single most important treatment that we have for frequent urinary tract infections. It reduces the risk of infection by half. And in fact, it doesn't have to be systemic. It should be local vaginal estrogen, either by cream, insert, ring, one of the many varieties of treatments that we have to offer.
So overactive bladder, one of the most common things that we see in primary care, women who say they can't leave the house unless they know the bathroom route and where to stop all along the way. So what are some of the common fixes that we can use before we end up referring to somebody like you?
So the tool that I start with always is a voiding diary or 24-hour frequency volume chart, where we ask the woman to measure how much she drinks in a 24-hour period, and then to measure each urination so that we know the volume that she passes each time. That gives us a lot of insight about how well her bladder is functioning, and we can give her tips about how to alter those things to improve her continence. Second important thing is pelvic floor muscle strength. And it's important to be sure that women can contract those muscles correctly by assessing that during a pelvic exam. Most of us weren't trained to do that during our residency or medical school, but you simply, when you have two fingers in the vagina for a pelvic exam, ask her to contract the muscles she'd use to avoid urination or to avoid passing gas. That's a more universally understood term. And you'll be able to feel whether or not the correct muscles are working, and then can give her verbal instructions about how to do those.
Word about medication, common medications that we can offer these women, their limitations, their benefits.
So there's a group of anticholinergic medications. The newer ones are more specific in order to limit side effects. They're anticholinergics, and they reduce bladder contractility. But they also can lead to dry mouth, dry eyes, and constipation. So being aware of that and prescribing treatments for those in advance is really helpful. There's a concern about using those medications with older women or women more at risk for dementia because of an association between those drugs and dementia. We don't know which is cause and which is effect, but that's a concern that does somewhat limit our medication use in older people.
Okay.
Beyond medication, there's some other really good treatments. One is referred to as PTNS, which stands for percutaneous tibial nerve stimulation. We place a small acupuncture-like needle into the inner aspect of the ankle and stimulate the tibial nerve with a small box, kind of the size of a cell phone. For 30 minutes, we do this once a week for 12 weeks, and then usually monthly for maintenance. And that is as effective as medication without any of the side effects. It's a very good treatment for women who can make it into the office that often. An additional treatment would be intravesical botulinum toxin injections, or Botox. We do this into the bladder about every 6 months to partially paralyze the muscle to limit the contractility of the bladder. And this can be very effective in many women. And lastly, more invasive but also a really good treatment is spinal stimulation, inserting a needle into the third sacral root and attaching that to an implantable pulse generator can give ongoing, long-lasting relief of overactive bladder. So many options to offer women if needed.
Let's go into stress urinary incontinence, and not much for many of us to offer from a medical point of view management other than the lifestyle changes that you've talked about. But talk to me about the surgical options that might be available, and a word about the controversy about mesh.
Okay, well, I'm going to first talk about, so an intravaginal pessary is another option. Here's an example of this. And both of them work in the same ways. They provide support to the bladder. So if you imagine this is the bladder and the urethra, with a cough or a sneeze, there's a lot of mobility. We put this in the vagina, the bladder and urethra can't move, and that eliminates the leaking. Surgery accomplishes the same thing. So this would be the type of mesh that one would use in a surgical procedure for incontinence. It's a piece about the size of a piece of Scotch tape. And this is implanted around the urethra behind the symphysis and now provides sort of a hammock to keep the urethra from moving too much during a cough or sneeze. So the controversy is about mesh used for pelvic organ prolapse, not for incontinence. So for incontinence, our mesh procedure is the best surgery that we've ever had in terms of longevity, and there are actually fewer complications with mesh-related surgery compared to our older surgeries. Just having them in the media has made them more frightening for patients.
I think this is one of the complaints for us as healthcare practitioners across the board, for primary care specialty, that patients do come in because it does have such a significant impact on lifestyle.
Right, and any of the treatments that make a difference in quality of life. Surgery is our most effective treatment, and so I really don't want to ever caution women against it because of the potential risks, because those are manageable. But always, we'd never recommend surgery as first line unless that's the only option that we have that will work. So,
well, thank you so much for joining us today.
A whole set of choices to think about. So definitely not something to ignore and just attribute to aging.
Absolutely. Thank you so much for your expertise.
Thank you.